Imagine you're at a routine eye exam. You feel fine, and then your eye doctor says they see a small freckle inside your eye. That tiny freckle is what we call a choroidal nevus, and even though it sounds scary, most of the time it is completely harmless. A choroidal nevus is basically a flat, pigmented spot in the choroid, which is the layer of blood vessels underneath the retina inside the eye. In everyday terms, it is like a birthmark or mole inside the eye. It is very common in adults, especially among white or fair skinned people, and it is the most common type of intraocular tumor. But remember that in this context, tumor just means a growth, not necessarily cancer. The main reason eye doctors pay attention to these spots is that a small number can slowly change over time and turn into a malignant tumor called choroidal melanoma. So we need to know how to watch them properly. Most people with a choroidal nevus have no symptoms at all and feel that their vision is completely normal. That is why these lesions are often found by surprise during a dilated eye exam when the doctor looks carefully at the back of the eye with a lens and the light. When symptoms do show up, they usually happen because the nevus is affecting the overlying retina. If the nevus is under or near the macula, or if it causes fluid to collect under the retina, the patient may notice blurred central vision, a gray or dark spot, or distortion in one eye. In simple terms, the spot itself does not hurt, but the changes it causes in the sensitive central retina can make straight lines look wavy or make letters on a chart look missing or faded in one eye. Some patients may also complain of decreased vision that does not improve with a new glasses prescription. For a beginner, it helps to remember that unexplained vision changes in one eye, especially if the fundus exams reveals a pigmented lesion, should make you think about the possibility of a nevus with secondary retinal changes. A choroidal nevus forms when melanocytes, the pigment cells in the choroid, grow in a localized area and create a flat or slightly elevated pigmented patch. It is considered a benign, non-cancerous lesion, and for most people, it simply stays there without causing any problems. We do not always know exactly why one person develops nevus and another does not, but we do know they are more commonly seen in fair-skinned populations and in adults. What really matters clinically is not just that a nevus exists, but whether it has features that increase the risk it might grow into a melanoma. A very helpful mnemonic that many eye doctors use is TFSOM-DEM, which stands for thickness more than 2 mm, subretinal fluid, symptoms with vision loss, orange pigment, melanoma type hollowness on ultrasound, and diameter more than 5 mm. Each of these features adds a bit more risk. Large studies have shown that if choroidal nevus has none of these risk factors, the chance of it transforming into a melanoma over 5 years is about 1%. But with each added factor, that risk goes up significantly. For someone just starting in eye care, you can think of a quiet, flat, small nevus as low risk and a thicker fluid producing symptomatic lesion with orange pigment as high risk that needs close follow-up or referral. Diagnosing a choroidal nevus and assessing its risk start with a thorough dilated fundus examination. On fundus exam, a typical nevus is a slate gray or brownish flat lesion with fairly smooth borders, usually without orange pigment or significant elevation. However, modern practice goes far beyond just looking once with an ophthalmoscope. Today, we rely heavily on multimodal imaging. Color fundus photography is used to document the lesion's location, size, and shape over time, which helps detect subtle growth. OCT shows how the nevus affects the overlying retina and can reveal subretinal fluid, retinal edema, or disruptions in the photoreceptor layer, which explain visual symptoms. Fundus autofluorescence can highlight orange pigment which appears as lipofuscin overlying the lesion and is considered a risk feature. Ultrasonography is used to measure the thickness of the lesion and to evaluate its internal reflectivity. A small nevus usually has high internal reflectivity, while a melanoma often shows low to medium reflectivity and a more solid appearance, sometimes described as acoustic hollowing. For beginners, it is enough to remember that imaging is not just cool pictures. It provides objective measurements like thickness and diameter that help you classify the lesion as low risk or suspicious and decide on appropriate follow-up intervals. Most choroidal nevi do not need active treatment. The standard approach for a stable, low-risk nevus is observation with regular follow-up exams and imaging to make sure it is not growing or developing new risk features. Typically, this means taking baseline photos and scans, then rechecking after an initial short interval, and if stable, extending the follow-up period. If the nevus shows growth or starts to develop multiple TFS-OM features, it is no longer managed as a simple benign lesion. At that point, the patient should be referred to an ocular oncology specialist or retina specialist who can decide whether it represents a small melanoma that needs treatment. Possible treatments for lesions that transform into melanoma include plaque brachytherapy, proton beam radiotherapy, or other forms of radiotherapy that aim to control the tumor while preserving as much vision and as much of the eye as possible. From a beginner's perspective, your job is not to treat the nevus directly, but to recognize when a lesion has changed or looks suspicious and to ensure the patient is seen by the right specialist in time. Accurate documentation of size, color, thickness, and risk features, and consistent follow-up are what protect patients from delayed diagnosis of melanoma. To wrap this up, a choroidal nevus is basically a freckle inside the eye that is common and usually harmless, but it deserves respect because a small number can turn into melanoma over time. For beginners in eye care, the key points are simple. Learn what a typical low-risk nevus looks like, use imaging to document and monitor it, remember the TFS-OM-DEM risk factors, and never ignore growth, new symptoms, subretinal fluid, or orange pigment. If you follow those steps, you will be able to manage most nevi safely and know when to call in an ocular oncology expert. Thanks for watching. If you want to learn more about choroidal nevi, be sure to check out the link in the description below. And I'll see you in the next video. Bye!